Let them know everybody's okay with the recording. That's great. We need to have this time like boom on time. But thanks so much, and will be time to review this material as well. So it's full benefit on recording. Thanks so much.
Jamie, take it away.
Yeah, so good morning, everyone. Really excited for this second session. We've really worked a lot over our capacity building series to kind of lay that foundation of clinical quality management skills and knowledge. And now we're really kind of jumping into implementation and kind of a robust application. So we can get started with today. Our focus is the Return to Care QIP project. And I think the next slides, maybe back to Oscar for a little reminder about the toolkit and all those pieces.
Yeah, it will be very quick. Thanks so much for every single one of you to come and join us on this one and work with this, building the culture of CQM in Dallas County. It is something like we are part of it. You can review previous links on the website link. The website is coming as well. The training series and YouTube channel and the toolkit. Please, if you have any difficulties getting in or getting the material, give us a call, give us an email, and we can work it out. Again, thank you so much for the time that you're dedicating on Monday. It's Monday. So come back to you, JB. Oh, Regina.
It's me. Good morning, everyone. Hey. This is our just an overview of how we navigate through Zoom. So you can I guess, first of all, you can go ahead and if you want, how you want to view, you can press escape to exit your full screen mode. If you'd like also to change your view options, you just hover across the top of your screen and it should allow you to do that. And what we ask is that you please place yourself on mute to avoid as much background noise as possible until you're ready to pose a question or make a comment. The chat room feature is also available for you if you'd like to go ahead and if you have any questions or would like to make any comments. We also ask you use the chat room feature to go ahead and just put your name and the agency that you're with. And so we can go ahead, hey, everybody, I see, there you go. And then this meeting, as Oscar mentioned, will be recorded and available for sharing after the meeting if you have team members that were unable to participate today. Next slide, please. Okay, so once you join the session, as Michael mentioned, I'll be tagging everyone, placing your agency name along with your name there. If I miss anyone, please let me know. I don't see anyone that has dialed in yet. I don't have my pictures in full screen mode. So if we ask if you have a number, if you're not calling in, we would like to know your full name and the agency that you're with. This will help us facilitate in assigning you to your breakout room or your breakout session. So please let us know that. If you'd like to add any additional information, which of course we strongly encourage that your pronouns, he, she, or him, you may do so as well. If you get disconnected and able to rejoin, please go ahead. We will put your name again and we'll go ahead and add your agency name. So that's what we'll be doing for tagging. Next slide, please. And as you will be assigned to your groups, that's what the tagging is for. And each participant will receive, if you see the little box there, you'll receive a notification to join your breakout room. So you can accept the invitation and you will automatically be moved into your breakout session. And then when the time is up, even if you don't accept to join back in, it will automatically click you back into the main group. That's all I have for right now. And now I turn it over to, is that Michael?
It's me.
Yay.
Thanks, Regina. And thanks for emphasizing so much, what we're doing in the breakouts. The breakouts are going to be a full 30 minutes today. I have my times written down, a little card here to make sure that we can dedicate 30 minutes to the breakouts. A lot of the workshopping is going to happen there. But overall for today, for our learning objectives, we want you to we want you to be able to walk away being able to name some approaches to conduct a root cause analysis and similar activities. Some of this is kind of repeating or re-emphasizing things that we spoke about in the series last year, but that's a principle of adult learning, right? So we want to just help to fortify that for you. Also, to describe how your organization's discovery results are the product of specific root causes. Now, you may not be able to do that today, but our goal is to give you the tools and resources so that within the next couple of weeks, you can do that. And then finally, explain how to develop change ideas based on your organization's root cause analysis results. And of course, in quality, it's all about change and change management, right? So you can see that our learning objectives are helping you to take your nearly crystallized or crystallized aim and to put it into action, to put it to work for you as you get your quality project rolling on the ground in your sites. Our toolkit is prolific. As Oscar already mentioned, we have already updated the glass cubes for subrecipients based on today's toolkit. And there are many, many resources that we have available to you based on the kinds of hints and themes that came to us based on your aims. So this is a really important time to park and emphasize that when we ask you to provide us with information about your project and how it's going, it's really great to share back with you different resources that we find helpful, interesting, or potentially compelling related to your project. So, you know, just to kind of plug that, to use those action planning forms, ask questions, and to share with us so that we can share back with you through our toolkit. So, pregnancy, substance use disorder, and HIV resources. English as a second language and HIV resources, migrants and HIV resources, medical neighborhood resources, referral management types of resources, task shifting and patient journeys. It's like drinking from a fire hose, folks. So definitely be kind to yourselves and perhaps focus on the things that are most relevant to you and share, share, share. As we know, steal shamelessly and share senselessly, right? So that's just a little bit of an overview on the toolkit. And I'm going to kick it back to Jamie to get us started for our main content for today.
Yeah, thank you, Michael. That really is like the Cadillac of toolkits. So we want to do a little bit of housekeeping. We can go to the next slide. This is really a dedicated time for talking about our return to care QIP. So a couple of things to just acknowledge as we get into that is that change is definitely in the air. This has been a really exciting journey with everyone. And as I mentioned before, we're getting into kind of the robust application of the knowledge and skills we've been building on. We have a lot of new processes in place, right? We have our clinical quality management performance measures that are driven by a new process. We have this new regional quality improvement project, which is going to be driven by this regional discovery across the whole EMA HSDA. And then we also have a new process for that experience evaluation, which is AKA client satisfaction surveys. So those are like 3 different swim lanes. So just a point of clarification, you know, the use of Qualtrics, that's really going to be for performance measures, which is not really where we're at today, not the focus of today, whether that be qualitative performance measures that are continuously reported. And then we're also using Qualtrics for the regional experience evaluation, you know, former satisfaction surveys, and that's done periodically. So we want to kind of shake out the Qualtrics survey mind frame from today's discussion, just knowing we have a lot of things going on simultaneously. And there are definitely some nuances between continued, which is the focus, which is what we're using for quality improvement projects, what some sites are using. So there are some nuances between those and the county supported iPads. So we wanted to put that out there. And the next slide actually is kind of this visual depiction of all this change I'm talking about. And so for me, you know, I conceptualize this by talking about swim lanes. I'm not a good swimmer, but this is what works. So we see on that top row, this is where we're at today, right? We've done our kickoff for the quality improvement project. We're doing some capacity building, and we're going to see throughout today's session sort of what's the trajectory, was the arc of this QIP project. There'll be a regional project every single year, right? So we're really getting to flex those muscles, and how do we do this as a region? When I mentioned Qualtrics and the performance measures and those other pieces, that's represented by this middle line with we've finalized our performance measures, we begin launching them, and then we'll go through revision. And then with the client satisfaction survey, CSS, also we call it experience evaluation. We've also done some piloting there. a launch, and we'll also do results. So it's just important to distinguish those three things. And today, really carve out time and dedicate our brain space to the quality improvement project. And I think it's back to you, Michael.
Fabulous. Thanks so much, Jamie. It's so important for us to be able to keep track of all of the different changes we have going on. And I'm really glad that we took the time to be able to share that with you. And, of course, if you or others at your agencies have any questions about how these things line up and work together, please don't hesitate to reach out to the AACQM team or to us. So now this next section is just a quick refresher on QI process as we start doing robust root cause analysis in our return to care project. So this is just a reminder, of what our trajectory is for the year for just this project. That's the top line, that Jamie had just been sharing. Here we are in June, and when we add, kind of our process steps are, most of you, I think, are pretty well finished with an initial discovery, and you're now starting to think a little bit about root causes. If you're still crystallizing your discovery process and your aim, that is okay. Sometimes, kind of thinking about what you have the power to have change over or influence, what populations are the right ones, it can kind of like be a little jumbly. So it's okay if you don't have a crystallized aim today, as we've already emphasized. But as we work our way into August, we're hoping that you will have pretty much wrapped up your root cause analysis and have identified tests of change so that you can begin implementing them. By the time we get to November, there should be a lot of information on the tests that you've been changing on the ground so that we can get a very robust cross-provider discussion going about what you found. And then we'll wrap up in January with a poster symposium, and then we'll start the cycle anew in March. So just a reminder, we use the model for improvement for the most part here, which is 3 strategic questions followed by PDSA cycles. And of course, the PDSA cycles, as we know, can inform or modify the strategic answers to these 3 questions, right? The idea here that our projects are not research, it's not, we have a model and strict fidelity. Quality is organic, right? And it grows and changes and, sometimes has a new branch come off of it. So just keeping in mind that we have a certain level of flexibility in our implementation of the model for improvement when we do our regional QI projects. So the questions plus PDSA cycles encapsulate our life cycle that we talk about. When we think about setting aims, really is the discovery process. You start to look at where you might want to focus, have a little bit of setting some measures that you flesh from your discovery learnings, and then you start to identify change ideas by taking root causes into account and to really bring those to life for your stakeholders in conversation. And then of course you test your change ideas or you implement, your QI project. So this is just a quick reminder that we have the model for improvement as, kind of our very, very, kind of broad bumper lanes and our thinking of the way that we create our QI projects. And, right now where I see us at as a system is we're kind of between these first 2 bullets, between setting aims and setting measures for the most part. So there are numerous QI tools that we can use when we work our way through a QI project lifecycle. And we might as well just click next so you can see or have that reminder of what the life cycle is: discovery, root causes, implementation. So many of you have probably used tools like brainstorming, collecting data, discussing with your stakeholders, maybe some flow charts of what your existing processes look like in order to complete your discovery. And some of you I know have rounded into your fishbone diagrams, your 5 whys, and drilling down. Something that we're going to emphasize today is that it's never too late to gain additional data on where you have pain points. As you do your root cause analysis, you might identify that a situation or an issue isn't with what you thought it was, but another process. And so collecting additional information on that process is encouraged and, a good thing, because that helps you to identify where you're going to place your effort in terms of testing your change ideas. You hear us say a lot, how much juice for the squeeze? right? So sometimes having that secondary opportunities to gather data on those pain points is really helpful and important for you to make sure that your project is going to be set up for success. And of course, you know, after root causes, we work on a number of different tools to go about testing change and to implement change and to formalize change. So just because we identify a need doesn't mean we know everything about that on its surface, right? And that's why we do root causes. No one is an island. No team is an island either. If you try to get away from the individual perspective by doing a team-based approach, that's helpful. But we need to dig deeper to really get at the heart of a problem. And in my opinion, root causes and drivers, they really can't be identified without the help of stakeholders. And again, just to emphasize that your team is a wonderful place to start, but even thinking more broadly beyond your team, how about anyone who touches a client related to a specific type of episode or a process? How about asking the clients themselves to be a part of this conversation and process? It's amazing the type of information that you get when you tap into that consumer voice and mentality, especially around root causes, because there are things that you think that you might have power over that, guess what? According to the consumers, you don't. So why would you put your effort there? And there might be things that you don't think you have power over, but according to the consumers, you do. So why not take a moment to take a look at that and to see what that would look like and the change ideas that would flow from a specific root cause that your consumers help you to learn about. And of course, root causes lend themselves to drivers for change that are tied to the individual change ideas that we're going to be testing to address root causes or to facilitate the driver that will help us to achieve change. So in 5 whys analysis, just to kind of emphasize some of those different tools that we saw, it's the root cause at the evil, the root cause is the evil at the bottom that really sets into motion the entire chain. And it's called the 5 whys analysis because typically if we all put our 2-year-old toddler hat and say, why, because 5 times, we get to that root problem. Some approaches are geared more toward identifying true causes than others. Some are more about general problem solving, while others are just about like supporting a core activity of root cause analysis. But it's important that you think about the tools that we showed on that one diagram where we had discovery across the top and root causes along the side, because there are numerous tools you can do. This is just one of the most common and popular ones. And plus it's fun to be 2 again. And it can be fun to do an exercise like this with your consumers to really help encourage them to be innovative and creative. This we're very familiar with. This is drawn from the IHI toolkit, and CQII NQC uses this tool an awful lot. Any of you who participated in end disparities or create equity, I'm sure you're familiar with this tool, but I just wanted to show it here just as a reminder that there are tools and instructions and formats available that you can take off the shelf to be able to do this. For driver diagrams, again, it's just a visual display of what drives achievement of a project aim. So it's kind of like a root cause or fishbone on its head. Instead of looking at the problem, we're looking primarily at solutions to drive success. So again, it's a shared view. We would use this to engage our stakeholders. And then of course, the great thing about engaging stakeholders, this works with a fishbone too, right? You engage stakeholders to create it, you engage stakeholders to share your results. It's a great communication tool to be able to keep the people involved, to let them know that you are doing something with their work and their contributions were meaningful. It's also a roadmap for testing change ideas, and you'll see some examples later on how you can use dots or other processes to prioritize with your stakeholders what you want to pursue in what order. And the change ideas basically become the basis of different PDSA cycles. So they need to be measurable, and then they're tied visually and structurally to the drivers of success and change. We're going to give you a tour of this in a little bit, but just a reminder that the QI report form plays with this as well, and you have a space to be able to mention what your primary drivers and secondary drivers are, and where you tie change ideas that you're going to be potentially testing related to secondary drivers, followed by a box where you can share a little bit about your results. And then we have the QI project guide as well that we'll be sharing later too. We just wanted to just kind of flash these up here to remind you that, you know, this is a project that we put a lot of thought and energy into designing the support available to you, not just these webinars, but the tools and resources available to you to help guide your work. All right, Jamie, where are we now?
Yeah, awesome. Thanks, Michael. We can go to the next slide. So just a quick reminder. So some of the overall, you know, EMA HSDA aims for this regional project, where we want to see change happen. We do want to see a reduction in the no-show rate of scheduled outpatient ambulatory visits at the funded subs by 10 percentage points. We want to increase access to medical visits. And I think Dell actually caught, we might need to do a little grammar check on that sentence because it did read a little funny. But we want to increase the rate of access to medical visits. And we also want to achieve viral suppression. And that viral suppression also puts us in alignment with achieving together. So we have some aims, you know, to reach by the end of the calendar year. And as we think about where we're at now, we look at where do we want to be, what are our regional aims, and then the next slide actually breaks down sort of where we find ourselves as a recipient, subrecipient family, right? So this is also a little bit of a teaser for how the breakout groups are going to be structured. As we start to break in and think about our aims, what are the aims at that provider level? You know, we just showed some of the regional aims. So how do we do the work in support of getting to those three aims? And this is where your agency autonomy and the unique makeup of your services and the folks accessing your services are really crucial. And so we've got 3 breakout groups, and we know some folks who, I think Michael maybe alluded to it earlier, you know, the aim might be like sort of drafted out, you know, but we're kind of want to work through some finalization. We've got folks where it's maybe a little bit more solidified, but again, they may still be looking at data from a different lens, but we see some themes too. So as you look at this, you know, it's pretty interesting to me in that first group, we see some kind of subpopulation focus, right? We have English as a second language. We have the pregnant women on Suboxone. And this is also where that toolkit material has been really hand selected to complement the kind of feedback we've seen from different groups. And then also even within group 2, we see a lot of different internal coordination. Maybe that's motivated by different things, whether it's merger or, you know, multi-site location or entity, but we have some, you know, internal coordination pieces. So again, I think we're really excited to dedicate a good half hour to these breakouts and say wherever you're at with your aim, if it's an early development, if you're finalizing ideas, or if you feel like, you know what, it's in good shape, we want to create this opportunity for peer learning. So we can go to the next slide. And actually, I want to park it just for a second and encourage folks to unmute themselves. Obviously, feel free to share the chat, share in the chat. But as we think about our aims and the identification of root causes, sort of the stuff that Michael walked us through, which is part of discovery, I wanted to open it up to see maybe for some broader sharing, what are some of the identified root causes folks have come across, identified in your teams?
Hi, this is Debbie Morris Harris from Prism. And if you would allow me to share my screen, I just wanted to float some ideas in front of the group just to get your feedback.
I don't know if, so I don't know if we have time to, you know, share at that level here, but I would love to be able to do that level in the breakout rooms. And I don't know, Jamie and Oscar, what you think about that, just because I want to make sure that we're focused on stuff that's tied to everyone's learning right now. I don't know. What do you think, guys?
I think that'll be actually very, very productive to share within the group. You have half hour, concise, everybody pitching in, and you are taking one of our consultants with you who got you like hand on hand. And when the breakout, bring it that will be addressed. If the time doesn't allow it to be that extensive, we can set up a time out of this meeting to do that and to keep on going and continue to support the project that you are have it for sure.
Yeah, I'll be in that breakout. We can definitely share some screen and then see what where there's alignment, what that feedback is in the breakout, and that can maybe be included in the quick report out. So any others, any kind of high level root causes? Okay, we've got some quiet Cathys versus chatty Cathys. Well, you know what? We got time in the breakouts, fam. I do want to say, I think what's really great about this from kind of part of that ACQM team, and I invite others, Oscar, Michael, or Regina, to share, what this project means. It really is a great opportunity to tackle retention and care from a regional level. And I think there's a lot of cool pieces, HAB's annual retention and care measure, the fact that we do have, if it works at the site level, the continued component to utilize and coordinate. So I think there's a lot of synergy and a lot of kind of unprecedented opportunity. And that gets me pretty jazzed up about this project and about the conversations we're about to go into with the breakout.
Just a quick comment that we all are doing something at the subrecipient level. You all are doing something for retention and care. Definitely. What we're doing now is compiling that and organize those ideas to collaborate as a group. So I'm pretty sure every single subrecipient have a lot to discuss in retention and care, because that is a big issue. Yeah. So please, let's go ahead.
Great. All right. So let's pull up from root cause to change ideas. So this part of the conversation is to help you think about how we move from where we're today into some next steps. So one thing that you could do would be to create a solution side fishbone, right? So we have the fishbone that's focused on problems, and we can create a second one that kind of matches solutions to problem. And you basically use your fishbone as a guide to create those potential solutions. You take handwritten notes on a whiteboard or a large piece of butcher paper or something like that. I like to do the fishbone that way as well, instead of on a projector using the PDF fillable form, but whatever works best for you, right? I then take my handwritten notes and I formalize them and turn them into an electronic version so that you can have a clean version that everyone can look at and they don't have to interpret with any chicken bones or holy water or whatever, what it was that I was trying to say. The solutions often then read similar to a change idea, right? Because you're asking people to help solve a problem. And you're then able to group change ideas and lists and ask the audience to rank and prioritize them. And so this actually becomes then the basis of your test of change strategy to be used in your QI project. Now, I wanted to walk through an example that is a couple of years old. It comes from Robeson Healthcare Corporation in Robeson, North Carolina. It's from 2013. And so here you can see this fishbone is focused on no dental services. And the idea that in rural North Carolina, this social justice idea that teeth belong in heads, right? So what is it about our inability to make sure that our community is championed in their ability to maintain excellent dental health and to keep their teeth in their head? So you can see some of the ideas that walked around here, and I'll emphasize some of these in process that, people are afraid of the dentist. They don't like pain. They hate waiting. They're told that they have this high anxiety encounter coming up and then it's 3 months away. Great. Now I have to worry about it for 3 months. Medical issues or complications. And how do I know everything to share? Do I just bring a laundry list of all of my health concerns and that feels like extra? And no, thank you. Scheduling, no shows and no appointments are available. And, if I did no show, then I'm told I'm supposed to pay something. And what is that? timelines, communication, you can see here that the level of detail gets to be 2 or 3 levels down for some of these. And this is why I like to put it in typed, right? Because this is hard to see for people if you're trying to have a conversation about really what works and what's compelling for folks. But, so you take that and you flip it around to make a solution fishbone. So I talked about process before, so I'm gonna focus on process again. So too many procedures, consolidate the paperwork, divide up some of the, procedures in a way that is clinically appropriate and also meets the client's psychological and also time availability needs. Afraid of the dentist, the idea that, having a conversation about what works for you and being presented with a menu of options for things so that you feel like you're making choices that work for you, whether you want to pull teeth or whether you want to do something else, is something that can be pulled out and played with. So you can see the list goes on and on. I'm not going to sit and read to you. And then it becomes formalized. I'm really sorry that the PDF version kind of like made the italics really scrunchy here. But what you can see, this formalized version, what they did was they allowed the solutions to kind of stand out and to have a conversation with their people living with HIV and their dental staff and their support service staff that are managing these appointments to figure out where they're going to actually, have the most juice for the squeeze. Now, in looking through some of these solutions, you can see that some of these solutions are actually pretty easy, low-hanging fruit, so to speak. And some of them are really hard. So like the idea that from a scheduling standpoint, you have limited chairs, you need to have people in them. And so it's hard not to avoid overlapping appointments. So thinking about the idea that talking to clients and talking to providers about their preferences and their expectations is actually easier, potentially than trying to add a 25th hour to the day or, add water and stir to magically create a new dental chair that you don't have. So what we wanted to show you here is that the conversation at this stage would be about presenting back to the community all the possible realms of solutions, and then to engage them in a conversation to prioritize. We can only do one thing at a time. What one thing should we do first? And then help us come up with the order of the things that we're going to test after that. So that is how you create a solution side fishbone. So driver diagrams in greater detail. On the left, you draw a box and you put the project name in it. To the right of that, you list a few primary drivers, maybe 2 to 5. And to the right of those, you list as many secondary drivers as you can think of. And you try to find a way to group it visually, either with boxes or with colors. You'll see some crazy Michael Hager stuff on the next slide where I take my butcher paper usually, personally, and put it up on the wall where we're able to talk through this with folks. So this comes from the New Jersey project I often talk about. This is from Cooper EIP in Camden, New Jersey. And this shows you how they walked through a driver diagram to increase mental health and substance use screening for their acute cases in their ID clinic. So the primary drivers they came up with to increase mental health and substance use screening is to affect staff knowledge. The behavioral health capacity of staff at all levels, not just the providers, but front desk people, concierges, the billing staff, everybody. Information flow is another primary driver in terms of whether or not we know who we're supposed to be treating when, what they need, and then how the information goes from the different provider types so that there is a team-based multidisciplinary approach that we've been aspiring to for decades in Ryan White. The patient flow, you can see that they thought it was one thing and then they kind of revised. It's patient flow is like a primary driver. So attached to each of these, you can see many secondary drivers. And then kind of extending from those secondary drivers, you can see change ideas. Now, all this craziness with the dots, as I had told you before, this process was done with a full cross-section of the clinical team. This is a large hospital in a relatively large suburban urban core city. It's kind of like one of those across the river from Philadelphia things, right? So really high need population. And they involved consumers in this dot setting process as well. And so we worked through and kind of talked through the merit of each of these change ideas and some of the things to keep in mind. To do this, we would need to change X, Y, and Z. We would need to train people on blah, blah, blah. So it allowed everyone to think about what is the most practical and reasonable. So you can see here that the most popular thing that they came up with was to create a kiosk form for the PHQ and other screening information, so that when people check in, they go to this little terminal and it spits out the form in their language so that they can kind of like respond to it. So after that, I think that they had empowerment of the entire team. See, if you see something, say something. Update the training plan for all staff. You know, and training plan like the way that we talk about it here: onboarding, maintenance, and remediation. Let's look at another example real quick, because I get excited. Oh, no. So here we have the primary drivers, the secondary drivers, and the change ideas. So let's look at another example. Here we have the same aim, because it's the same project, right? But just a different part of the state. This is from Henry Austin Health in Trenton, New Jersey. So same idea, where we have you know, our primary drivers, our secondary drivers, and our change ideas. And just so not to belabor the point here, you can see that this health center, they focused on workflow an awful lot. Increasing the lines of communication, increasing FTEs and positions, exploring changing their space configuration and the flow of clients through their actual clinic, maximizing a scope of practice so that people practice at the top of their licensure, increase administration and patient coordination support, the stuff that happens in the background that's, you know, the consumers don't see it, but very much plays into consumer care. And so you can see here, similarly, we have change ideas that focus on each of these different secondary drivers. Some of the secondary drivers, in fact, have two change ideas, which is also okay, right? Because there are many ways to skin a cat, as they say. So there's not a need to necessarily limit yourself to one to one to one. You know, you just want to be kind to yourself and not make perfect the enemy of good. The most important thing that I find in this process is the conversation that you have with your stakeholders, particularly your consumers, about what's a problem, how do we solve a problem, how do we know when the problem is solved. So something that's really important to remember is that there are things that are outside your control. And I know that you know this, right? Because you've been battling this since the beginning of your programs and probably the beginning of your careers. Misogyny, racism, and homophobia, oh my. And let's not forget about generational poverty, xenophobia, transphobia, the housing shortage, food shortages. You know, the list goes on and on and on, and we are very well familiar with this. Of course, our state partners in Achieving Together think about this as well. Our federal partners in US EHE and Fast Track Cities think about this as well. And so, you know, we can, you know, be like, no, that's not for us. But I think that it's very powerful, especially when you invite consumers into the room, to help identify non-traditional partners that you could collaborate with. So shifting the focus of your work to things that you can address, you know, and saying things like, we can share all of these needs and unmet needs, you know, that we're hearing you express with some of our other partners, like a different community-based organization. Thinking about Dallas, there's the Southern Black Policy and Advocacy Network, SBAN. Thinking about churches or synagogues or mosques or temples. Thinking about other groups that just specialize in these areas, like a trans health empowerment organization. There are many different groups that can help you potentially to unpack and unravel these issues, or that you can just punt the issue that you see to them. They are probably going to be grateful. Your assistance in finding these issues might play into their needs assessment. And then I think that another thing that's important is that if you do have an ongoing conversation with any of these other non-traditional partners about social determinants that you're trying to address together, you can include small updates to your audience. So remember, folks, we're working on this, but I want to remind you that you had mentioned housing as a problem. So we are still working on that with this other partner. These are some of the things we're working on them with. Just a quick update so that they continue to feel heard and seen. But I think that the most important thing to remember about this is to use the group time wisely. Steer back to what you can practically influence, because you will have people say that, racism is the problem. If we don't solve racism, we won't solve anything. And racism is a very important contributing aspect to many of the problems we have. But there are other things that we can do in our power. And, we don't want to waste time by talking about things that are really outside our power. It is a good use of time to talk about how we can address some of these needs in another way. I don't know, Jamie, if there's anything you want to add.
No, I totally agree. I think, I think there's a balance to honoring, when that thing comes, whether it's racism, stigma, some of those pieces that are so complex, or there's a lot of intersectionality packed into things. It's going to come up in the discovery. So how do you then balance what's efficient, what's an efficient use of time? Because if teams sort of cycle through ideas or spend time in corners where you have less influence of change, people don't believe in your project, people get burnt out, and people feel like nothing ever gets done. So how do you unpack those things in tangible ways so that they don't go like left alone, but you're also not spinning your wheels? Okay, one at a time. So I'm actually really excited because that question leads us into the next bit. So yes, we said it before. I typed it in the chat. One thing at a time, y'all, and that's hard. Everybody has a lot of ideas, and everybody's very committed to the work. But here is a very exciting QI tool. It's a priority matrix. Feel free to use a little hand emoji or clap emoji if you've used one of these before. But for folks who've maybe already drafted up their driver diagram or their fishbone diagram, and your next step is to list out tests of change ideas, kind of like what we saw with Michael's New Jersey example. Priority matrix is your friend. It's a simple tool. This is one of the reasons why I love it. You can do it kind of anywhere, anytime, with anyone, whether you have paper, whether you have a whiteboard. There's also some virtual platforms. So this tool helps you prioritize and work categorically in your decision making. So you have informed choices, you have better time management. It can be totally customized. And typically, and what we're going to show an example here, is organizations will prioritize by looking at impact and effort. So you may have heard of like an effort yield matrix, things like that. There are a couple different, terms you maybe come across, and you might recognize it here pretty soon. But really, the steps are pretty easy peasy. You sort of take each task or activity, each test of change idea, and you place it on a matrix. And as a group, you find consensus, sort of what's the level of effort here, what's the level of impact, and then you can kind of rank where these ideas are. And the placement in this matrix determines its priority. And then once you've prioritized, then assignment can start to happen. Who's going to take this? Who wants to take the lead on this, or who do we need to pull in order to make this test of change task or activity happen? And this also helps you see where you have consistency or where there's maybe divergence. But now that I've talked like a little about what it is and how you do it, for me, I'm a visual learner. So I think the next slide is actually more my jam, because you start to see one. Oh, and again, this is how you go, what do we do first? Where do we even start? Because if you feel that, this is your friend. So this is a priority matrix. So you can really see it's just kind of a crossbar here where you have that horizontal bar goes from a low effort to a high effort. The vertical goes from a low value to a high value. And what this does is it creates 4 quadrants. These 4 quadrants is how you have that informed decision-making and time management. You got to do it now section. This is that stuff that's like, this is an easy modification. We could get this done within a week. It's adding a checkbox on something, or, very simple pieces. Then you have the do it next, which may take a little more planning, but it's going to have a very high value with a tinge bit more effort. Then you have the do it if or when there's time. This is stuff that is a lower effort, but also not super high on the value. So it's like good, but only if or when you have time. And then it really helps you identify the don't do it. This is where we don't want to spin our wheels or waste our energy, because this is something that takes a lot of effort, but it does not really hit the value mark so well. So let's see. So that's, again, an example. You can draw that on your butcher paper, on your whiteboard. I think the next click actually shows you Miro if folks are using a platform such as that. There's an example there. And this is also something you can do with Post-it notes and take your test of change ideas. If we go to the next slide, sometimes people have so many ideas. So let's say your team, you did your driver diagram or your fishbone, and now you have all these ideas. Sometimes don't even worry about drawing the matrix yet. Just jot all that info down. Literally, this could look like the driver diagrams that Michael showed and those different tests of change. Boom, boom, boom. Sometimes folks will number them, idea 1, 2, 3. Sometimes they letter them, idea A, B, C, D. And then if you click again, we'll see how those thin pieces show up, right? So idea 1, we want to implement this when we do our follow-up calls. Okay, team. The team said idea 1, that's not that hard, low effort, high value. So that fell in the do it now category. So sometimes numbering or using letters helps keep that matrix a little less busy. You don't have a whole lot of words on it. And this just becomes one of those pieces where that do it now, those are quick, easy tests of change. We talk about small cycles. This is where you want to start. And then the do it next, once you get through all the do it nows and you learn and you sort of roll your information in the next PDSA, stuff like that, then you can go to the do it next. So this is just a resource we wanted to make sure folks, knew of a priority matrix or effort yield matrix. If this is something you or your teams want to do and you want a little more one-on-one, reach out to us. We're happy to help walk you through how to prioritize your test of change ideas. And I think now we're going to go into the importance of kind of keeping track of all that stuff and documenting those tests of change and really just prioritizing one at a time. And again, all staff levels, everybody engaged in the process as well as the community are super important in saying what's the value level on this, because we might think something is not valuable, but the person doing the work in the process is like life-changing for them. So it's important to have that feedback. If one idea doesn't work well, make some tweaks to the way you're implementing it and move on to the next one. And again, take really good notes. Part of quality improvement is failing forward. The unexpected can also be awesome. So take good notes because we want to see how your learning is progressing. We're going to move into showing you the form, which has to do with like how we report and share, but also keep in mind at the end of this year's regional, we're going to do that poster symposium. So this documentation is important. And I think Michael's going to pull up. He kind of gave you a snapshot of the PDSA form earlier. But again, we've really carried the whole QIP project lifecycle with your aim, your discovery, your root cause analysis, your test of change ideas. So you have all of those different components at your fingertips. And we created the Quality Improvement Project Guide, which is a pretty phenomenal resource. Again, it can remind you about those different components of the model for improvement. There's a section about testing changes, which is where we're getting ready after discovery, you implement, right? And then assistance also with aim statements, if you're still kind of finalizing that, and different pieces. There's also templates like a driver diagram and stuff like that. I don't know, Michael, if there's anything else you want to highlight about this guide specifically?
No, basically just you can see here that it's drawn from many evidence-based resources and it's available to you. And so as you're working through the different steps and phases of your project, please use this tool and let us know if you have any questions or concerns about it as we go. And of course, we have our QI project report form that that tool helps to point toward. Jamie, I don't know if there's any areas of this you want to point out that maybe I didn't point out before.
Oh, well, this came out of a great one-on-one, and so I want to thank some folks on the line. But if you scroll down, actually, when you think of your aim, there's an opportunity when you don't have to define your measure like so explicitly in your aim statement. You can say like retention to care or retention and care. You don't have to drill down as much, because within your outcome measure, that way if you have, well, there's retention and care for our like 35 to 44-year-olds, but also, you have more room to do your numerator, denominator, and description. Your aim, again, is kind of a SMART objective, so it's a little bit more of a higher level view. So I just wanted to point that out on the form, because I think that's been really helpful, and that's something we've kind of come to conversation in the last week. So.
Absolutely. And there is support available to you if you have any questions about this form, what it means, where to send it, and all of that as well. And, we're a small, tight-knit community here in the Dallas region. There's only 11 of you. So it's easy enough for us to work with you one-on-one when needed as well.
Oh, I will mention there is a tab on that same form with the completed one, so you can sort of see an example. So if you do get a little like stuck, there's a completed example within that workbook.
That's right. And the last one that we have, we don't expect that folks are going to be rounding the corner from root causes into planning tests of change just yet. But by the time we get to August, some of you will be. So we wanted to make sure that we reemphasize this tool that's available to you as well. Like once you have tests of change that you're ready to process, you can actually use this form to help you design that test of change, soup to nuts, so that each of your change ideas gets this level of attention, so that you can have practical, well thought out PDSA cycles that work well for your groups. And this is not the, there's a different contact information for us. I guess I pulled up the wrong one in my haste. But that tool and resource has all the different information that you need available to. And I'll make sure that I posted the right version on Glass Cubes late last night.
Michael, there is a comment up from one of the emails that I received that in Glass Cube, some of the files has some difficulties opening up. I mean, any suggestion on that?
So yeah, whenever you have an issue with accessing a file on Glass Cubes, please let us know about that. We hadn't realized that some of our CQM performance measurement specification materials were acting up. So thank you, Del, for letting us know. We went through and do some clicks ourselves, and then we send a report to the CQII to get it fixed. So, these resources are here for you. And so we really value and need your feedback when things aren't working to your expectations and needs.
Thanks.
Great. All right. So I think this brings us to a poll. What do we got here? So, oh, go ahead, Jamie.
Okay, no, it's cool, it's cool. Yeah, I can see it. Yeah, so poll time. We wanted to do a quick poll in advance of the breakouts. So we want to have folks go ahead and start responding. The first question we want to pose to the group is asking, our team is ready to prioritize different root causes identified. We want to check in and see where you're at. Maybe you strongly agree, you're neutral or unsure, disagree, or strongly disagree. As folks begin to think through that, the second question, I am confident in our team's ability to identify root causes that we have limited influence over so as not to waste time and energy. Let's gauge your confidence. Are you feeling very confident, fairly confident, feeling neutral or unsure, or not confident? The third question, our team is ready to select tests of change based on our root cause analysis, so they can identify practical solutions to problems that they have influence to change. Would you strongly agree, feel neutral or unsure, disagree, or strongly disagree? And the fourth and final question, our team is ready to share our root cause analysis with different audiences. Would you agree, strongly agree, feel neutral or unsure, disagree, or strongly disagree? And it looks like we have about 62% of the vote. So we'll give folks some time think through those. And well, then Michael, I'll have you share the results.
All right, let's go ahead and share these results. So what we can see here is that quite a few of you agree that you're ready to prioritize different root causes that you identify, but one of you disagrees. So, you know, we're going to be reaching out to folks again to just make sure that you feel well supported, you know, in taking these next steps and making sure that you feel like you are heading on a pathway to success. You know, it's great to see that folks feel fairly confident in their ability to identify those root causes that they can actually influence. But as you work your way through, if you feel stuck or have any questions or concerns, you know, we are here for you. Here comes another one where we have a couple people disagreeing that they're ready to select change ideas. This is so important. This is a critical step in the QI project lifecycle. So we'll definitely be reaching out to you and, you know, reach out to us as much as you need as well. I feel like group calls are wonderful. It's wonderful to workshop with each other, but sometimes it's the individual needs that kind of are the sticking points. And so it's just great for us to provide that level of customer service to all of you as subrecipients, an important part of the fabric of our community response. And then finally, in terms of sharing root cause analysis with different audiences, we know that some of you haven't gotten to this point yet anyway. So I'd imagine that that's kind of what quite a bit of that is and the unsureness. But if you're looking for different tips or tricks to create different 20-minute, hour-long, 5-minute types of presentations and engagements with people, there are many ways to go about this. It doesn't all have to be face-to-face. You can have something and then have a comment box that people respond to. We are just full of ideas and innovation and happy to share and explore all of that with you. All right, so I'm going to punt it to Regina, and I'm going to do just another quick check of our room list here to see if I have everyone assigned.
Okay, so for when we're going to break out, it's going to be broken into 3 different groups. And what we're going to try and accomplish today is some folks, one group will be folks who have established their aims or somewhere close to it, or folks who have had sketched an aim out, trying to work and need a little help with finalizing it. And then those folks that do not have aims and need help getting started. So as we mentioned earlier, just wait for the little pop-up box to come and you can hit accept and you'll be sent directly to the group, which group you're assigned to.
Fabulous.
And Jamie is next, right?
I'm just going to open the rooms. Okay, here we go, everybody. See you in 25 minutes.
See you.
Okay, see ya.
All right. So we're going to keep this room here for me and Julie to help Jonathan a little bit with the project that you're working on in dental. Lorna, what program are you with? Oh, Lorna is still connecting to audio. All right. Let's see. All right, Jonathan. How's it going today? Mr. Bingham, Dr. Bingham.
I'm here. I was just on mute.
Cool. So you are lucky in that you have our full and undivided attention. And I'm so glad to have Julie here too, because, you know, as you know, achieving together is such an important issue of our time at the moment. You know, so we want to make sure that we can, you know, get that together. Just really fast. Mr. Gute, I forget what agency you're with.
Good morning, Mr. Hager. Parkland Health and Hospital with Piper Duarte.
That's right. Let me send you over there.
Thanks. Sorry, I was a little bit late.
No worries, no worries. Let me see if I can do this.
I'm gonna go to a place where I can turn on the camera.
No worries,
I'm in a
Jonathan.
dark room right now.
And Lorna and Nisa, what groups are you with?
Hi, this is Lisa Ortiz. I'm with Legal Hospice of Texas.
Oh, you're in the right group. Yay.
Yeah.
All right, cool. Really, really great. So what we're trying to do here with both you and Jonathan from Dental is to think about how your project, how your organization services fits into the HIV care continuum, and thinking about how you can participate in a project like this one, even though you ain't got nothing to do with OAHS services, you know. So I don't know if y'all have had any internal conversation about this, or have done any thinking, or if you you know, kind of want me to take the reins of the conversation. But I'm interested in hearing from you first.
Yeah, I can give you kind of rundown on where we are with our project. Regina called me last week and asked me kind of for the same thing. So I figured it was her interpretation of our project which put us in this group.
Well, I wanted to put you in this group because, you know, even though you have a solid idea, I think that you might help other folks who are kind of positioned similarly to you.
Yeah. So we're still waiting. I'm waiting for the person who's doing our business intelligence to come up with a final report on our data so that we can actually move forward. But we've defined what we're considering in care, and we're running all of our clients that are funded through Ryan White, and essentially using encounter data, just dental coding, to determine who is keeping their periodic visits. We're not really looking at treatment visits, but actually people that are doing their preventive care, coming in for exams and preventive stuff. Because treatment, you know, when people are having pain or they have something that needs to be treated, they prioritize and that come in. But when people are purely on preventive care, they're less incentivized by other things to come in. So we're really looking at people that are on 6-month recalls and 3-month recalls, depending on their periodontal, their gum status, basically. I don't know if y'all super aware of oral health, but we're looking at where they are in the system and if they're missing those appointments. And so we're running all of that data, and we're going to do as much demographics with that as we can so that we can look to see if there's any trending on age or gender or race on who is missing or who is not staying in care. And
I love
then
this.
yeah,
So,
so that's where we are.
Professionally, I was partially raised by Helene Bednarz in Boston, so I am very aware of oral health stuff. I saw all of the pictures as a young person living with HIV, and she scared me right into the dentist seat. So, you know, in terms of thinking about your project and the application of this project, while we're thinking overall in terms of outpatient ambulatory health services, this is about thinking longitudinally, like outside of this scope of outcomes, and thinking about, we don't talk about mortality as like the true endpoint, you know, outcome, you know, or survival as the endpoint outcome, but that is, I think, where we position things when we think about oral health. We're in such a weird place in this country where, you know, like, this is a social justice issue. Like, I was happy the other day in pride conversations, even here in New York City, people are talking about teeth belong in heads, you know. And how do we get people to understand, you know, this issue that the preventive care, like it really leads to, you know, it can lead to death, you know, or
Right.
survival, you know.
Oh, and just kind of on that topic of things, I mean, it's not an HIV thing.
No,
it's
not.
It's an oral health thing.
Whoop. Whoop.
People have had really bad experiences. It starts with kids. I mean, I tell everyone I know that has a kid, get your kid to the dentist before they're a year old. Start
Yeah.
going. The insurance pays for it. If you don't have insurance, you can have Medicaid for your kid. Because if the first time you take them is when they have a cavity when they're 6 years old, they're going to hate it for the rest of their life. And so, yeah, it's a mess. But yeah,
So let
I
me
wanna-
ask Nisa. Nisa, have you thought about this at all in your organization?
Hi, Michael. No, actually, I'm so sorry. Regina Waits, we got in contact over the weekend, and she was supposed to send me something with some homework from the April meeting because I believe I missed it. I don't think I was on the email list, so I'm a bit behind. So this is the first that I hear about this project.
No worries. So each organization, if you're the person who's the contact organization for CQM, please let us know so that we can update our lists. I know that.
I am. And I
Okay,
did
cool.
tell her that on
Okay,
Friday,
good.
so I think she added me to the list now.
As you saw early on, changes in the air, we have a lot going on. So, we're just glad that you're here with us now. Let me go ahead and bring up the action planning form from last time, just so that you have a chance to take a peek, because it's all about these questions of discovery. And so it's about thinking about where you're positioned within the HIV service system and the role that you play. Let's see. Here it is. Okay, so I'll pull this up. And this is available to you in Glass Cubes, Nisa, and we can get you access to Glass Cubes if you're not already a part.
Yeah, she mentioned that to me, but she didn't actually send me the link yet.
The
So
invite.
yeah,
Okay. I'll make a note here and I'll send it to you. Invite.
thank you.
If you can just drop your email in the chat room, then I'll just go ahead and do that real fast for you.
Okay.
So what we're trying to do here is to think about how we can put together something that works for our organization and our culture and our process, but then also lends itself to the bigger project. Jonathan's project.
I think, Michael, a good spot, just because I've done this a couple of times with staff in our agency,
Yeah.
is the project document. There's the 4 bullets that describe what the non-outpatient medical providers are doing to support the project. I think that's a better spot for you to kind of show her what's going on.
Yes, that was brilliance from Jamie, because she has worked in housing spaces for so long.
So you've got the
There we
starting
go.
there, non-OAHS providers.
So this is an interesting thing because, when we think about a group like legal, this is thinking about, you're a supportive service that is essential to people's ability to maintain ongoing care. You likely are helping to address key social determinants of health, see key psychological, psychosocial barriers to people's ability to even consider being in care. And then, of course, incidents and issues related to people's care that they're actually receiving, particularly when they have negative circumstances. So you're entering information about your clients, into Aries based on your service information. And one of the things that our surveillance partners at the state and county have said is that, an organization like yours, Nisa, could, come up with a list of people that you're serving now, and they'll tell you who is in care and who is out of care. And this then allows you to think about, is it appropriate for our agency to ask certain types of clients about their care and their ability to maintain ongoing care? That may work for you, that may not work for you. That's just one idea that kind of pops out of my head for an organization that's very specific like yours, because you don't necessarily have a focus, Nisa, that Jonathan has in terms of thinking about, the services dental provides aren't necessarily related to OAHS, except they have a similar endpoint outcome of survival or mortality.
Yes, that is actually a question that we ask at the registration period with most of our clients, because they're either being referred from somewhere or they're not. So for the clients who are being referred from somewhere, we automatically know they have a case manager. They're either being served at the Resource Center, Parkland, or one of the Ryan White entities. And then I would say that maybe like 25 to 30% of our clients are not in case management, do not have a case manager, either don't need it anymore or aren't aware of it or are just dropped out. So those are the clients who have to get us their forms personally and email them to us because they don't have a case manager to do it for them. So we do actually ask that question usually, and our attorneys do ask those questions as well, depending on the case. and that's usually in the client's case notes. So like, yeah, that's an interesting project. I think that's something that we could maybe try to pay more attention to or try to implement at our registration process.
Well, you got mad components on the table too, right? You're already asking those questions. You're already aware, first of all, you're already aware of this issue as an important issue. And obviously it's not your first day. You've been doing the service for a long time.
Yeah.
So you, not only are you aware of it, but it's actually a part of process. So you can start to do a discovery. Is this a practice? Like it's just something that this is how we do business, or is it in a policy and procedure? Is there a formalized, structured way that we engage our clients in this conversation? How do we, what type of advice do we give to clients depending on where they fall and their responses? Is that just a practice, or do you have established policy and procedure and standardized formats and approaches that you take? So you can see here that you can take something that you feel like confident and you do well, but it's in the realm of practice, and bringing it into the realm of like something that's more of a policy and procedure, a protocol, is a great application of this project for a site like yours. It's lean and mean and allows you to pursue what you're excellent at already. I don't know, Nisa, if there's, go ahead, Julie.
Hi, Nisa. I don't know if I've met you yet, but I've had interactions with your organization over the past few years. And I know I just popped into my head a process measure that you might be able to work on is care coordination and the eligibility. I know Jonathan also mentioned to me that you have the same issue when you get referrals in. Oftentimes you don't get the paperwork that you need to move forward with the support service that you provide. And so it kind of delays things. And so that's like an overall outcome measure that you can use step measures as far as like a process for care coordination of getting those important eligibility documents, even though it doesn't seem like it's related to outcome, if we can't get them access easily without a big, bunch of paperwork hassle and having folks redo paperwork, it's a real downer for patient experience or client experience. So just throwing that out there for a possibility of a, step measure you might use.
Well, and Julie, that's getting better anyway, because the
good.
way that program monitoring was done at Dallas County for so long encouraged us to do our own eligibility with every client, because they essentially wouldn't look at the referral documents, and they wanted it dated within like, instead of being dated in their birth month or, dated in an appropriate time, they wanted it dated, they went by the date of first encounter with us, rather than so that they would have to redo their paperwork. And so Dallas County has gotten a lot better at the monitoring thing and a lot more coordinated in the last couple of years. So their system isn't actively encouraging us to basically ignore eligibility data or packets put together by another agency and doing it all on our own. So that's already been a great improvement. So that's
Awesome.
less of an issue than it used to be.
Well, that's great to hear. So maybe we don't need to do that. But it seems like from feedback from the field to the AA that changes have been made, which is quality improvement in action, right? And I bet we didn't document it. So those are the important steps we got to always remember. Like if this happens again, we know what we learned last time, Yeah.
So kind of talking about what Michael was talking about for, what was it, legal hospice, is that Nisa?
Yes.
One of the things I brought up to the QM team last I talked to them about this project was my initial confusion was, are we really looking at our own clients and seeing who's in care for oral health care? And is that the project that we want to do? Or were they wanting to direct us to say, who are we serving that has been lost to care for OAHS? And so they didn't really have an answer to that. They seem to like us to do our own patients, our own data, and are worried about our oral health care, people that are in care and or out of care in oral health. But and I've tried to wrap my brain around how this would work, because the data systems don't talk to each other the way they would need to make it easy. But it kind of jives with what you were talking about, where maybe Thomas runs a report and my computer, I'm going to have to do something in a minute. My computer's down to something, 8 minutes. Thomas runs a report on people that have stopped being seen at an OAHS. They don't have those services in areas any longer, but they're still being seen for oral health because maybe they've prioritized that. Or maybe they're being seen at legal hospice because they're trying to do a disability claim or something like that. And they may have fallen out of healthcare, but they're trying to get their disability claim because they're incentivized to get that cash flow. And so that finding out who Dallas County thinks has been lost to OAHS, but is still getting served at a food bank or at legal or through dental, that may be a better project, but it's not going to be easy.
So this is the thing that's, I think, really important. Julie, I'm really interested in your perspective too, like, what a blessing to have our state partner on the line with us too, right? Because we can hit several birds with one stone. And that's one of the things that we're trying to do here. I think, Jonathan, the reason why you didn't get a definitive, like, do one versus the other, from the team is that there is a lot of validity to the clinical arguments you're making about taking care of the people that you already have in front of you. Now, the project was in fact designed for you to think about how you can help with OAHS services. And there are some things that work in our favor and plenty of things that don't work in our favor and make it a hard project. And so I think that there is that recognition on the part of our county partners that this might be a decision point that's best left up to you, because again, clinically speaking, you are very much in the trenches with OAHS providers thinking about survival versus mortality, and the suffering and loss of quality of life that comes from morbidity related to caries and everything. So, I would say that it's up to you, and you can discuss with your stakeholders, the project is designed like this, but we have this opportunity. What's the best fitting project for us, and our needs? All of this has changed, working with the state and the county surveillance partners in this way and creating, like, we're basically building hula hoops for us to start all working as a system, and that's going to take time, and it's going to not always be easy. And so no matter what we do, we're going to end up all having to be patient and to muddle through it together. But I know that we have the ability to do that. And I think that, being able to see yourself and have that autonomy to actually discuss with your own stakeholders what's best for us, I think is going to be something that's a sea change in the way that you've interacted with the county in the past. So I don't know if, you've had any thoughts, like, do either of your organizations have sets of consumers that are your go-to peeps to kind of like review realms of possibility, or have you thought about maybe trying to start up such as, kind of like a system or group?
We don't really have anything that does that well. It's real unstructured. It's basically me talking to clients when I need to or when they need to. Mm-hmm. We don't really have much of a structure.
How about you, Nisa?
Yeah, we don't either. Like you mentioned earlier, we don't actually have like a policy that makes us ask the client if they're in care, but it is a question that almost always comes up. So it's kind of just case by case basis with the attorneys. Our system is we receive referrals from all the different Ryan White entities and some hospice agencies. And we go through each of our referrals at the beginning of the week and reach out to these clients for the first time. If we're missing any eligibility documents, then we do a second round of calls and try to get them to get it to us. And that's when the question comes up: are you in care? Do you have a case manager? It's usually individuals who are like newly diagnosed that don't know a lot about Ryan White yet and are still learning, that are not in case management. But we don't have a system where we like keep track of that or who's in it and who's not.
Yeah. So there's, go ahead, Jonathan.
I think they have, that might help you with that is I think they have consumers on their board, at least a couple. So they may have through Tony or someone the ability to have a pretty good interaction with some consumers.
Good. I think that the important next steps are to just have some conversation with folks, like, what's the best project for us? Like, we have some realms of possibility. You know, what's an appropriate level and practical level of stakeholder involvement? If consumers don't necessarily come to you, it might be arduous to try to like add water and stir and create a brand new group now. Maybe there are some folks that are favorite clients or clients who like are the ones with always have an opinion that when they're in the, you know, as they're leaving the chair, hey, we're wanting to do this thing and I just want to run an idea by you real quick. That's a back of the napkin kind of counter. That's a similar type of project to, you know, discovery activity that it sounds like you'll be doing too, Nisa, since it's attorney by attorney. You'll ask people, hey, of the 5 clients that you've interacted with recently, how many were you able to identify their care status? And, you know, when you ask this question a couple of times, people be like, oop, I forgot to ask. And you're like, come on, we got to do it. That's part of the change process too, right? Like helping people to round that corner in terms of what is my actual job? How do I do that job? You know, and what information is really helping us to take this robust team-based approach. So I think we need to wrap up now, but you know, it sounds like you're both on a great track. Did you want to share something, Nisa?
Yeah, I like that idea. I think, I mean, we see a certain amount of clients each week and they're already on the schedule for the week by the end of the week. Like Friday next week will be booked. So I can try to going forward and I'll meet with the attorneys and see what they think. Just kind of going over however many clients they had each week and trying to see how many of them are in care. Yeah, I was a bit behind on this, so I do apologize, but I will go through the notes and talk with the attorneys and see what they think about the project.
Be kind to yourself. Be kind to yourself. You're here now, and that's what counts, my friend.
Thank you. Thank you.
Let me open the curtain and bring back the folks. End it now. All right, I'll give them the minute break, the minute warning. And to whoever is the 214 number, I hope that this was an interesting conversation for you and you were maybe in the right group. You can press *6 to unmute yourself.
I would say, Nisa, don't be afraid of the dates that are in the planning documents. The project kind of got a later start than was designed. So when it's talking about April and May, don't freak out. You're not that much further behind everybody.
Exactly.
Good to know.
Exactly. As I said, like whenever you're doing change, there's going to be dust in the air and it's hard. So that goes for us too. Thanks for pointing that out, Jonathan.
So is a new
And
group coming in?
What's up?
Is a new group coming in, or what are we doing now?
So now we have ended the breakout sessions and we're just going to wrap up the call by sharing with you the next action planning form. So the form from April, we have one for this time. And then also thinking about what other next steps we have in the project. So seeing as we are close to time, we're going to skip the report outs. And Jamie, do you want to walk us through the action planning form? You may be muted.
I 100% was muted. Awesome. Yes, so we do have an action planning template, which is an example document that's got some thought prompt questions. And these are other key questions, and this is actually what our breakout group kind of closed on, like what's sort of most critical as we think about moving forward. So again, our next huddle up is going to be in August, and that's where we want to report out on tests of change. So these are key questions to move you from today's capacity building into your action planning, so you feel prepared for what comes next. So a key question would be, how will your discovery activity continue to inform your QI project planning? Remember, you can do a small test of change and go back to that fishbone with a test of change idea or your priority matrix and say, here's what we can do next, right? So as you continue to advance, are there additional data needed to inform your decisions? A second piece, are there any special root causes beyond your control, but might be in the purview of a partner, an organizational partner, right? So I know one of our groups was talking about persons of trans experience, right? Are there ways we can pull in knowledge or expertise from others maybe to learn beyond where our current scope maybe is? Another key question, how will you present your aim and root causes to a wider audience? This is interesting because on our polling question, this had the lowest level of kind of confidence or readiness, partially because it might not be ready to share yet. But this is definitely something to think about, whether it's your CABs, your advisory boards, also just team meetings, right? There's plenty of opportunities to share with a wider audience. And also, how are you going to pull in that feedback and elicit that feedback on your root cause analysis to make sure that the change ideas you do that you want to test are really, most impactful with the lower level of effort, highest value of impact. And then a fourth key question is, how will you engage your audiences to prioritize those change ideas? So those kind of go together, right? As you share out, you can also inform your prioritization. We want to give some time for question and answer. Maybe we're right at time. You can help me manage that piece, Michael. But yeah, I wanted to open it up.
Any major questions or concerns before we show you our next steps in terms of upcoming webinars and wrap for the day? All right, well, we are here and available to you if you have any that occur to you after the webinar. Definitely don't hesitate to reach out. And obviously, if conversation with your colleagues raises anything else that's important, don't hesitate to reach out. Regina, what do we have coming up here?
So we have in August, well, the actual date we have is August 21st. We're going to do our testing changes. Then November 21st, we're looking at healthcare neighborhoods. And then in January, our grand finale will be Return to Care Poster Symposium. And each of these will be 90 minutes as we have them listed here, length of duration. And so that's where we're headed next.
I think, Regina, one thing, quick correction. I think we need to set the actual calendar. It's 8.
Oh, that's
August
of 2021.
I checked, I'm like, who's coming to work on Saturday? They get an award.
Right. None of us will.
But we'll be setting these actual dates soon and getting those out to you so you can mark your calendars, my friends.
Yes.
And just a quick reminder, by the time we get to August, you should have completed your root cause analysis and begin early tests of change. You should certainly have all of your tests of change kind of identified and lined up by that point in time. And we'll be reaching out to you really soon to see if you have any other questions or concerns that will affect your project. And I'll just quickly punt it over to Oscar for words of farewell.
Sure. It's too bad that we didn't share actually the brain ideas and brainstorm the result of the breakout groups, because we have some very nice, interesting discussion around that. And we need to extend and open the schedule for questions and support and work together on that, because there is a lot of things to do. There's a lot of moving pieces. Please send us your availability and request the time that you can do it. From Dr. Morris Harris, Victoria, please send us that email, work it out so we can build whatever you have at this point. We can work it out, that process, same there with every one of you. Then we appreciate your time. We appreciate the help of your consultant. It's the best that's happened to CQM in the Dallas County, and that is on Chairman HSDA. Please, a big round of applause for these two guys. They are. And again, thank you for your time on Monday. Thank Justin for the late response on the email and the text again. Appreciate that.
Thank you, Justin.
Anytime.
Any
Awesome.
comment, any question, please send us an email. for the appreciation of your time is 11:32. We don't want to go over on your time. I know that you are a busy people.
Thanks, everybody. Have a
Bob.
wonderful
Everybody.
day. Happy Monday.
Take care.
Cheers.
Thank you.